EV-201 Cohort 2 was the sub-study within EV-201 that looked at the role of enfortumab vedotin, which is an antibody-drug conjugate that binds Nectin-4 and delivers a payload called monomethyl auristatin E in a specific population of advanced urothelial cancer patients that had progressed on first-line immunotherapy with a PD-1 or PD-L1 antibody, and tested enfortumab vedotin in that context. These patients were all naive of platinum-based chemotherapy in the metastatic setting. And the primary purpose of this study was to assess in the 89 patients who received at least one dose of study drug, the activity with respect to confirmed objective response rates, duration of response, in a population of patients who were cisplatin-ineligible after receiving first-line immunotherapy. So in this, it was a single-arm study, and EV-201 was a parallel cohort, a single-arm study. Cohort 1 was already presented and was the subject of FDA approval in December 2019, and that was the role of EV in the platinum refractory and IO refractory setting. Cohort 2, which is the other arm of this study, which is the data that I presented, looked at enfortumab vedotin dosed at 1.25 mg per kg on a days 1, 8, and 15 schedule out of 28 days, so 3 weeks on, 1 week off, in 89 patients who received at least one dose of study drug. In patients who basically with advanced urothelial cancer who'd received immunotherapy in the first-line setting and then were cisplatin-ineligible. And the role of this study really was to assess kind of what is the activity of EV in this patient population. The standard of care otherwise would be gemcitabine and carboplatin-based chemotherapy, which has been around for 30 years now or close to it. And the purpose of this study really was to understand, is this an effective treatment option in patients who had progressed on first-line immunotherapy? In the patients who were treated in this trial, the primary endpoint, which was essentially confirmed objective response rate, was 52%, including 20% of patients achieving a complete response. 88% of patients had at least some decrease in tumor shrinkage. So basically, majority of patients had at least some decrease in their cancer. Importantly, only 9% of patients had progressive disease as their best response to treatment. What essentially that highlights is that the majority of patients will achieve some measure of disease control with enfortumab vedotin in this setting. Importantly, the duration of response was just short of 11 months, at 10.9 months. And so what it collectively highlights is that not only do the majority of patients achieve some decrease in tumor shrinkage and get disease control, that disease control lasts for a while. So to have a duration of response of that length is quite meaningful. And in totality, this shows us that this is a quite active option in patients with metastatic disease. What we also saw, were the safety signals were pretty much consistent with what we have seen in other studies of enfortumab vedotin in this patient population. I will point out that we had 4 treatment-related deaths on this study as assessed by the treating investigators, 3 of which occurred early in the course of treatment, within the first 30 days after the first dose of study treatment. And these were mixed in etiologies in terms of how these patients presented, but ultimately the common denominator was that these are older individuals with a high body mass index of greater than 30, suggesting that overweight or obese individuals were concentrated in this group who had early deaths. I should point out, though, that there were many other patients with high BMI that tolerated the treatment quite well, but this just happened to be the common denominator amongst these patients. In totality, what this data shows is that this is a very active drug in patients with metastatic disease and could be a very effective treatment option in patients who progressed on first-line immunotherapy. These data, along with data from EV-201 Cohort 1 and the recently presented EV-301, which demonstrated a survival benefit against a third-line chemotherapy, data from EV-201 Cohort 2 basically adds to our growing evidence of enfortumab vedotin in advanced bladder cancer. Collectively, we see response rates between the range of 45 to 50% in all of these trials. And essentially, this shows us that this is a very active treatment and is broadly applicable. Many of the safety concerns that we have around chemotherapy are non-overlapping with enfortumab vedotin, save for neuropathy. It can be safely given in patients with poor renal function. And it highlights that this is quite an active drug in advanced disease, and the future trials are now going to further assess its role in combination with immunotherapy in the first-line setting, where we see the highest response rates, north of 70% in the early phase trials. In total, it tells us that enfortumab vedotin-based therapies are likely to become the new standard of care in advanced disease and perhaps in the first-line setting very soon.